Hello friends, I am Dr. Ankit Madharia. I am an orthopedic and endoscopic spine surgeon. Today I will be demonstrating a very interesting case of a down-migrated L5-S1 disc herniation in a 25-year-old female. This lady had complaints of back pain relating to her bilateral lower limbs, right more than left, since past 15 days. The onset was quite sudden, and she was unable to walk. She was unable to stand due to her pain. And when she came to me, she had not slept for 4 days. So we can know that she had very severe back and leg pain, and which need to be addressed. So we got her MRI done, and what we saw was there was a huge L5S1 down migrated disc herniation. Now these kind of migrations are classified as very severe or very high migrations, because it is reaching beyond this disc space height, and as you can see it has gone beyond the pedicle of S1 vertebra here, and in the axial sections you can see that it is occupying the central part and it is lying behind this bone, the down migrated fragment. Now, I address these kind of herniations by transforaminal surgery under local anesthesia. Why I do it? Because it is very safe and effective in dealing with such cases. A lot of people think that such high migrations are difficult to operate, but the purpose of showing this video is to show that how easily we can tackle such difficult situations if we know our technique very well. And I'll this video is going to be a bit long because I'll be demonstrating the entire surgery, in which I'll show you the endoscopic picture, my personal working picture, and as well the X-ray and CM images. So this is going to be 30-35 minutes long, and I am going to show you the every each and every step that we have gone through in treating this patient. The first step that we do is draw our skin markings. In this case, the first line that we draw is the horizontal line across the L5-S1 disc space. The second line that we draw is goes through the spinous process, and it denotes the that target for our disc surgery. The third line that we draw is actually parallel to the disc space. Now, in this case, although we draw our line parallel to the disc space, my entry is usually going to be slight towards the head. Why is it so? Because I want to target the down migrated fragments and I want to come little oblique like this. And I don't want to go into the disc, I just want to stay epidural or half in and half out at the disc level. And my target is basically to target this part of the spine and going slightly over here. So in this case, I have gone a little 2 centimeters proximally on the lateral third line that I have drawn. The next part will show you the exact needle insertion and cannula insertion into the L5S1 disc space. Now, after drawing the lines and prepping and draping the patient, I would insert my needle into the L5S1 disc space. As you can see, the patient is under local anesthesia. I am asking her about whether she feels any pain. In the AP view, I have put my needle into the just lateral to the lateral pedicle line, and it is almost a mid pedicle line of S1. In the lateral view, it is reaching the posterior vertebral border line. Now this is the ideal placement of our needle to reach the L5S1 disc space. Now you can see that my needle is going oblique and it's not parallel to the disc space. Now this has been done intentionally so that we can achieve our down migrated disc fragments and we can reach those fragments. I gradually push my needle into the disc space, and I usually inject a little bit of local anesthetic into the disc space also. Now you can see here that the needle is going up to the near the midline, and it is uh, in the posterior 25% in the posterior 25% of the disc space. So that is the very ideal trajectory that I usually need for reaching the down migrated disc herniations. At this point of time, I'll change the needle with a guide wire, and over the guide wire I'll insert my cannula. Now this part of surgery can be little painful to the patient, so I usually ask my anesthetist to give her a little bit of propofol, so that he or she remains calm and does not feel much of her pain. As you can see, I am inserting my dilator over the guide wire, and we stop while we after I reach the lateral pedicle line. I check my position in the lateral view and I withdraw my guide wire from the dilator. Then we gradually hammer the dilator into the disc space. Now patient is under local anesthesia, but this part of the annulus has been anesthetized, so it is virtually pain-free for the patient. And you can see that my dilator is pointing towards the lower end plate. So that is exactly where I need to be. Here you can see that my dilator is reaching up to the midline, and that is where exactly I need to be. This is the cannula, and I'll place the bevel facing towards the head of the patient so that the exiting nerve is being protected and does not get catched between the cannula and the dilator. We hammer the dilator gradually into the disc space. This is also done under local anesthesia, and patient, you can see patient is lying comfortably. This has reached the mid pedicle line, midline, and that is exactly the place where I need my cannula to be. In the lateral view, now you can see that my cannula is lying exactly in the posterior 20 to 25% of the disc space where exactly I need to be. This is also lying little bit superficial, that is little bit part of it is in the epidural space, so it is probably half in and half out view that we would be seeing when we insert our endoscope in. You can see the endoscopic picture. I have actually fast forwarded this video by 1.3 times so that you can better appreciate each and every step. As we enter the disc, the first thing that we can see is the part of annulus that has gone into the disc with the cannula. The first thing that we need to do is remove that part. What you see here that I am doing is, if you could appreciate, is I am pointing my graspers to anteriorly, that is away from the nerve root. I would orient you first. This part that you see here is towards the head of the patient. This part, that is the 9 o'clock, is towards the foot end of the patient. The 12 o'clock is towards the back, and the 6 o'clock is anterior. The patient is lying prone with the head on our 3 o'clock and the foot at 9 o'clock. We begin by removing the subannular part of the disc. Now what you see here is half in and half out view. That is in the center you could see that there is a part of annulus is there, and over here towards the down towards the 6 o'clock what you see is the nuclear fragments. Now as soon as we have entered, we have, because our targeting is so good, it is so precise that we have actually landed at the tail of the down migrated disc herniations. And what you are seeing now is I am trying to grab that tail of the down migrated disc, uh, which we would soon be able to catch. Now this guy you can see as patient's father. Now I usually ask my patient's relatives or someone who are quite anxious, so that they can be in the operation theater and they could calm my patient so that they remain calm throughout the procedure. That is very helpful, and that helps me develop confidence in the mind of patients and their relatives. The thing that you see here right now is the tail of the down migrated disc that we'll be grabbing and pulling it into our cannula. Now you can see that it is quite stuck into the annular fragments, and it is not easy to grab these fragments. So for these kind of difficult herniations, I usually use a tooth, the forceps which has jaws with tooth in them. So it will hold it and it will not let it go. Now at the start of our surgery in just 2 to 3 minutes. You can see our first fragment is out. That is the first part of disc herniation. The second thing you can see here, you can see lots of blood here, and that is the active part of herniation that was causing her pain. This one. So within 3 or 4 minutes, we are already have removed our disc herniation of the surgery. And you can see such a large piece that was almost around 4 centimeter long, that was compressing on her S1 nerve root. You can see it beautifully. And at this moment, the patient's pain has completely gone. Now, if I ask her, she will tell that her leg pain is gone and she's probably dozing off or sleeping because her pain has been relieved. Now, just because we have removed one large fragment does not mean the surgery has ended, and we have to search for all small fragments that are lying there. Now, that is exactly what I am doing here. As you can see, my grasper is always opening toward this lower end plate. Now, why I am doing this? It is because the tail would have escaped from this region, and my target is very precise. It is at the lower end plate where the migration has occurred. Now this is a radio frequency probe that this serves two purposes. One is it clears the field, that it shrinks the tissue so that my field becomes quite clear and the visibility increases. Secondly, it coagulates the bleeders. So again the visibility increases with that. I withdraw my cannula and you can see this is the annulus. The down here is the nucleus part, this is the annulus, and this bubbles, that fat you can see here, that is the epidural space. These fats are lying around the nerve, and whenever you see fat you must be aware that nerve is very close to your where the fat is. So we are very much into the epidural space, half in and half of you, and I use my annular cutter to cut this part of annulus. Now, why this cutting is required is since I need to see the epidural space and I need to see the nerve, I'll have to take out that part of annulus from here. These annulus is very hard structure and it cannot be just pulled out by our graspers, and it usually needs to be cut, especially in young patients. So I cut my annulus, and as you know, there are a lot of epidural veins lying over the annulus, so that needs to be coagulated. Now this is an articulated left biting curette that I have from Karl Stoss. What I am doing right here is I am trying to detach that annulus from the lower end plate with that piece of bone. So what? So this makes my entry into this part of the cannula very easy. As I detach that annulus, like annulus from their bone, it is very easy now to safely go into the epidural space here. All of my bites are targeted at this lower end plate because I know that if there is a fragment lying there, I'll that if there's a fragment which is down migrated, its tail would be at the lower end plate. So always targeted surgery. Uh, Always our bites are very targeted. They are very limited. We are not exploring the disc. We are not going here and there. It is we know where the migrations are, and we are just targeting that area and leaving all the normal disc aside. So what this is the bony structure that you can see is the upper end plate of S1 vertebra, and that is the epidural space. I'm just trying to work on that edge, edge of the where the disc space is there and where the dura would be lying here. And I insert my articulated hook in that space over the ledge. So what the hook is doing is when I insert it in that position, I see it with a CM and you can see it is going inside of that S1 pedicle. So if you remember our MRI images, the disc herniation was lying in this region. I insert my hook there and I just rotate it. I sweep the floor. So if there's any herniation lying in this region, so this hook would go and sweep this entire area. So this sweeping movement would bring out all those down migrated fragments which are extruded into our disc space or into our field. Now there are also some longer hooks which I'll be using subsequently. The purpose of using a longer hook is to reach further more distally. Look, I have reached beyond the pedicle now, and I'll be using this hook to sweep all this area. I'll just going anterior to the dura and sweeping the floor, just clearing it off and bringing any extruded fragments in my field. Uh, Now, when you remove that, you can encounter some of small fragments which might be hindering your vision. So it's better to clear them off before proceeding, or before, if you don't see anything, it's better to clear everything before you go and find your targets. So that's what I'm doing. I'm using a small cup shaped grasper to remove those redundant tissues lying at the inferior end plate here. Now, this is the first time that we are seeing our neural structures. If you could appreciate here, where the cautery is, I'm just trying to palpate, use my probe of cautery as a palpating instrument. I'm not using it to coagulate. I'm just palpating where the nerve is and what structures are there. And this region is where the S1 traversing nerve is. This region. You would soon see it. Uh, so I would again use my grasper to clear that lower part of the disc space, and just remove all that redundant part of annulus and all those herniated disc fragments from the lower part of the end plate. Now, there are some surgeons who feel that it may cause nerve injury, but I must tell you that this patient is awake when I am doing it. So, doing or pulling the nerve is very difficult. Very difficult. If you want to pull it, then only you can pull it. Otherwise, accidental pulls are quite rare because the patient is awake. As soon as you touch the nerve, they'll feel the radiating pain going to their legs, and they would just tell you, and it is very difficult to injure nerve. Now I think you can better appreciate the nerve here. This is the traversing nerve, the first clear view that you are seeing here, and you can see this is the part of annulus that is hard and collagenized, which is still compressing here. So what I tend to do is I take small bites of that annulus with my flexible grasper. As you can see that it is lying towards the not at the center of the field but away from the center. So I'll be using a flexible annular cutter. Using such flexible instruments have their own advantage that they can reach uh, the periphery of our vision, and I think that every endoscopic surgeon must have these instruments to effectively tackle all those problems. I'm just trying to bite off little bit of annulus so that it becomes loose and can be subsequently taken away by our graspers. Now this is a cup-shaped grasper. This is very atraumatic, and it is just used to pull out loose fragments uh, out from the disc space. I'm just trying to fish out any loose fragments which might be lying here, which may result in reherniation if we leave them there. So the you can appreciate the picture quality is very good, and we can see the nerve and everything is so magnified that it is very difficult to damage any structures here. This is the RF probe. I use a plasma cautery because it is quite powerful, and you can see how beautifully it is shrinking all those structures. Now you can very well see our traversing S1 nerve root here, uh, and you could also appreciate that this part of disc is still compressing, although the nerve is free now. But I like to completely decompress these region. These are the epidural blood vessels that are bleeding, and I'll subsequently coagulate them with my plasma cautery. Some more bleeders here. We'll coagulate them first before going inside again. Now, doing such down migrated herniations may cause subsequent bleeding. So, you must be ready with your pressure pump or some device that increases the pressure of your irrigation fluid. Now, this is a flexible this is a regular annular cutter that I'm using to cut that part of annulus which is lying anterior to the traversing nerve. You can see it here. Now you can appreciate that I have rotated my endoscope slightly and I've turned it to one side and I am holding a grasper to other side. Now this is because I do this so that I can see the tip of the instrument. If I put endoscope and my grasper in the same line, I won't be able to see the tip. So I rotate my endoscope to see the tip of instrument. I can see so that I could see where it is biting and what it is biting. So these are the bleeders, that is the epidural vein, and can be easily coagulated with our plasma cautery. We must be very careful that because we are very close to the nerve, we must never touch the nerve with our cautery. And uh, usually, patients tell us that they are feeling some pain or tingling in their leg if we are close to nerve. So if the patient is awake, that is very safe for us. If the patient is asleep, you may never know that you have injured or you have cauterized around the nerve. So it is always advisable to keep your patient awake, and you should always inform them well in advance that if they feel any tingling or current kind of sensation going through their leg, they should immediately inform so that you are never damaging those structures. Here I am just putting my cannula back into the disc space, and this also removes the marginal osteophytes and some part of the end plate cartilage. So you can see this is the cartilage that has come out. So the removal of that cartilage will help us to visualize the disc space better. As you can see now, I'm just removing the loose disc fragments anterior to the nerve root, and I have again rotated my cannula to one side and I'm using the grasper uh, at a different angle. So this is the traversing nerve. Now this is the tooth forceps that I was talking about. So these tooth graspers are very good in removing such adherent fragments. And as you can see, the decompression is quite good right now, but still I would like to explore and remove these fragments so that they do not cause or they do not result in a reherniation. So I just like to remove these part of the redundant part of annulus that you can call, although they are not causing compression right now, but I like to see my nerve very clearly and very free. Now the thing that I am doing now is I am going over the edge of or on the posterior surface of the S1 vertebra, and I am trying to remove any part of disc that might be lying there. So my grasper is going on the posterior surface. This is the posterior surface, and I'm trying to get all those loose fragments out from there. That so this again, this is a different kind of grasper. This is a flexible grasper with tooth. Now this is very beautiful in a way that it can go just beyond beyond the straight line, and it can go uh, around the pedicle and remove the fragments from there. So what I am doing now is going anterior. You can see this is the S1 nerve root. I am going anterior to that. I'm using my grasper as a dissection device. So the grasper goes, pushes the nerve root pushes the nerve root away and removes the fragment that is lying anterior to it. So these are the various equipments or tools that you must have to do a good work or do good work efficiently, not struggling enough. And as you can see, it is just 17 minutes and we have already decompressed uh, the entire thing, and we are just now the thing that now I'm doing is I'm just searching for any loose fragments that might have reached there or that might be lying there. The nerve is actually free, but I just want to be very sure that there is no remnant or residual disc So I'm just going anteriorly using my grasper as dissection tool, pushing the dura upwards and going and grabbing it out. Whenever we are working in this lower zone, we must be careful that it will bleed, and we must be ready with our irrigation system or pressure system, so that we could increase the pressure at this moment to stop those bleeding or improve our visualization at that moment. Already the disc space is very free, but you can see that some residual disc fragments are lying there, which I am trying to remove now. Now I'm quite satisfied with the decompression here. So I'm just doing what I'm doing here is called as annuloplasty. In this process, we shrink the loose ends of the annulus. We try to coagulate them and seal the hole that we have created in the disc, so that further reherniation chances of reherniation are reduced. Also, this process will ablate any sinovertebral nerve that may have grown into this disc. So the back pain will also be treated by coagulating this part of the disc. So the annuloplasty serves two purposes. One is to coagulate any bleeders and shrink this hole so that reherniation does not occur. Secondly, it will ablate the sinovertebral nerves. So that is very important part of the surgery towards the end. I always do it, and that has resulted in very reduced chance of reherniation in my cases, and reduced chances of back pain post surgery in all of my cases. This is again some redundant part of annulus that is lying here, although it is not compressing, but I'd like to get it out so that I don't have any residual leg pain or back pain after the surgery. I hope you can appreciate how clear our vision is and how effectively we can do this surgery in a very short amount of time. Just 20 minutes have elapsed now, and we have completely done with our work here. Just to be sure, I'm clearing out any tissues, and if you if I could show you, this is part actually the middle part of the spine right over here. So we could reach beyond the midline by transforaminal route, and the central and paracentral herniations are very easy to be done by transforaminal route if done very if we know the trick. It is not very difficult surgery. So I think I'm done now. Just checking the subannular part for any loose fragments so that we don't have any chance of reherniation. And small fragments are just coming out, and when I'm very sure that there are no fragments left, will just come out. So I think this is it. The nerve root is completely free. I put a guide wire into the disc space, and I withdraw my endoscope and the cannula. Over the guide wire, I insert a needle, and through that needle, I inject a little bit of 1 ml of depomedrol. Now that helps me in reducing the post-operative pain, and requirement of any pregabalin also reduces. You can see just a small 7 millimeter incision on the side of her back is sufficient to remove this down migrated disc herniation. Disc herniation fragments that we have removed after the surgery. You can see the first fragment is very large. It is almost 3.5 4 centimeter long. Second is also a large fragment. We have small fragments that have come out. So such large fragments can be very safely and effectively tackled by a transforaminal surgery. Doing this surgery under local anesthesia has its advantage that it is very safe, and using our flexible instruments and our hook have made a surgery very easy for us. Other thing that we can do is doing a inferior oblique pediculotomy. But in my practice, with the use of these flexible instruments and hooks, the requirement of doing an oblique pediculotomy has reduced, and I can easily go away without removing any bone now. This is the immediate post-operative.
कोई दर्द नहीं है?
You can
दूसरा
see
पैर भी उठाओ।
this patient is actively
ठीक लग रहा
lifting
है?
her leg,
ठीक,
and
ओके।
there's no pain.
कमर में पैर में कोई दर्द नहीं ना अभी? ठीक।
So with this surgery, we can ensure that we are doing a very safe job and very effective job, and immediate results can be seen since it is done under local anesthesia. So this patient was in so much pain that she was not able to lie comfortably in her bed, and immediately after surgery, both her legs are quite pain free, and she's very happy about her surgery. So that's it. This is the hospital where I practice. This is Gayatri Hospital, situated in Raipur, Chhattisgarh, which is central part of India. Uh, I am Dr. Ankit Madharia. I am basically an orthopedic surgeon, and I have been trained by Dr. Satish Chandra Gore into doing transforaminal endoscopic spine surgeries, and that's it. So this is how we do our transfemoral surgery, and I would like to have your comments and how you would have done it, and if you have any question, please don't hesitate to put it in the comment sections. Thank you and have a good day.